Well, I'm Randy Wong. Thank you, everyone, for joining us. This is our April edition of the Treatment for Floaters. It's the April webinar. And what I'd like to do in the next 30 minutes is go over just a few slides to generate some questions and then discussion. And then I think later on, Chrissy's going to chime in and talk to you a little bit about her part and how she plays a role in coordinating anyone interested in coming in for a visit to Northern Virginia. Does that sound about right, Chrissy?
Sounds good.
Okay, so let's get started. I'm Randy Wong. I'm a retina specialist in Fairfax, Virginia, in the United States. Fairfax, Virginia is about 20 minutes from Washington, D.C. I have two websites. The one most of you know is vitrectomyforfloaters.com. My mainstay is retinaeyedoctor.com. Now, I must tell you that this webinar is for informational purposes only. This webinar does not offer medical advice, so nothing should be construed as medical advice. The information on this webinar is only offered for informational purposes. You should not act or rely on anything in this webinar or use it as a substitute for medical advice from a licensed professional. The content of this webinar may become quickly outdated, especially due to the nature of the topics covered, which are constantly evolving. The materials and the information on this webinar are not guaranteed to be correct, complete, or timely. Nothing in this webinar and nothing you or I do creates a doctor-patient relationship between you and the webinar, between you and me, or between you and Randall Wong, MD, or Retina Eye Doctor, or vitrectomyforfloaters.com. Even if you try to contact me through this posting of the webinar or conversations through the webinar, you are not creating a doctor-patient relationship. Although I'm a doctor, I am not your doctor until and unless there is a written agreement specifically providing for a doctor-patient relationship. Okay, having said that, I welcome everyone here to our April webinar. What I'd like to do today is go over a few slides that may actually help answer some very commonly asked questions that Chrissy and I get quite frequently. I only have about 4 or 5 slides, and after that we'll ask questions, have our question and answer period. What I have here right in front of you is an illustration of the vitreous with floaters in the vitreous. And if you pay attention to the large arrow where it says macula, in this illustration, just notice that the floaters are a certain distance from the macula. With vitrectomy, it doesn't really matter where the floaters are positioned, whether it's near the lens or near the macula, because as we'll see, vitrectomy removes most or all of the vitreous. And it doesn't matter if it's in the so-called premacular bursa, which is very close to the surface of the retina, or close to the lens. So this is a good illustration of where the floaters reside. They're in the middle of the eye somewhere. When retinal tears occur, they occur in the anterior part of the retina, and that is denoted by this kind of gray circle. The area underneath the gray circle from here to here is really what we call the anterior retina. And it's this area which is where all the tears or holes will occur. The posterior retina rarely, if ever, can get tears. And we'll see why in just a moment. By the way, all these illustrations are presented by pretty much the best ophthalmic illustrator in the world. His name is Mark Erickson of JaredDesign.com. This is a schematic or an illustration of a posterior vitreous detachment. It is this area here that is starting to separate from the surface of the retina in the back of the eye. And in this instance, the floaters are here right in the center of the vitreous. But this is the posterior vitreous. And now you can see that if the floaters were close to the macula and you had a PVD, they're going to move forward so that removing them becomes a piece of cake. Now, I made this slide just tonight to show you that the anterior retina or the anterior vitreous is from this line forward towards the front of the eye, whereas the posterior vitreous is from this line backwards. So this is the posterior vitreous, and this is the part that separates most easily from the surface of the retina. If I were to notice a retinal tear during an operation, this illustration shows that I could use a laser placed inside the eye to go around and treat that tear or hole. And again, all tears or holes are going to be found in the front half or the anterior retina. Don't be shy, guys. Oh, here we go. David asked, Dr. Wong, I saw you in March in Dr. Nguyen's office having a PVD in my second eye. Both eyes have had a PVD now. It was noted that I have cataracts. You recommending having cataract surgery before vitrectomy. I believe that I will have cataract removal surgery in 2 to 3 weeks in Houston, Texas, assuming no complications. About how long after that should I wait to contact Chrissy for arranging a visit with you and having the first vitrectomy in one eye? I would say, assuming that your cataract, I would assume that if your cataract surgery goes well and your healing or your postoperative course is uncomplicated, give it a good month to 6 weeks. You also don't know how much your vision is going to improve after having had cataract surgery. So in theory, it's possible that you may not really feel you need a vitrectomy just yet, but give it a good 4 to 6 weeks. I don't think there's anything special about that, but definitely by then you would know if there are any potential complications from the cataract surgery. Bob Watkins asks, when does infection occur, if any? By infection, I assume you're meaning endophthalmitis, which is the infection that I worry most about. And that's the infection inside the eye that could potentially cause blindness. Typically, most cases of what we call endophthalmitis, this is the infection inside the eye, occur within the first 3 or 4 days. In cataract surgery, there's a latent form which can happen 2 to 3 or 4 weeks later. It's a special type of infection related to the intraocular implant. So to answer your question more directly, for vitrectomy, we should know within 2, 3, or 4 days if there's any potential complications. Jose says, I'm a 24-year-old man. I have floaters for 13 years. My doc said that my vitreous is attached to the retina, so no PVD. And I wouldn't expect that at age 24, by the way. And I really need a vitrectomy. My floaters, sorry, everything's scrolling up. And I really need a vitrectomy. My floaters are so bad. What would you recommend, PVD, vitrectomy, or core? Well, as most of you know that who've been following me for a while, I'm pretty adamant, especially with our young patients, that we seriously consider inducing a PVD. And if you go back to the slides, the reason is if you see the PVD starting here, the vitreous can all move forward, and it's very easy for me to most efficiently remove more vitreous. This also allows me to remove more vitreous off to the side, and thereby, in theory, reducing the chance of developing frill. Ralph Kressel, how long is a vitrectomy last? A vitrectomy should last forever. You only get one vitreous. So whenever we're removing your vitreous, that is the same vitreous you were born with. It does not regenerate, so the effect should be for forever. Tyler says, thank you for your time, doctor. Thank you for thanking me, Tyler. So an individual on a forum indicated that the vitreous helps filter UV light from damaging the retina, and hence after a vitrectomy, it's critical to wear sunglasses outside for the rest of one's life. Is there any truth to this? Never heard of that. There is some truth to the natural lens filtering, the natural lens which becomes a cataract from filtering UV light. Haven't heard so much about I've never recommended to any of my patients that they need to wear special glasses after having a vitrectomy. So I'd say probably not that authoritative. Michelle says, approximately how many FOVs have you performed and how many resulted in any vision, permanent retina damage, etc.? I'm trying to assess the odds of something going wrong. I've been in practice about 24 years, having done quite a few vitrectomies. I don't know how many exact FOVs I've done, but every operation I do involves vitrectomy, and FOV is synonymous with vitrectomy. There are patients that I've operated on with potentially blinding conditions, retinal detachments, diabetic retinopathy. Their outcome has not been that terrific, and you would have to say that the disease won in that instance. For patients that have had or required just a vitrectomy for vitreous opacifications or floaters, I think we've had one in the last 5 or 6 years, which potentially may have had some vision loss, and that person was kind of lost to follow-up, and I'm not quite sure what happened. In my career, I've had possibly one episode of infection. The chance of something going wrong is unlikely, but that doesn't mean that you should just jump into this without educating yourself. So that's a really good question. Aaron says, hello, Dr. Wong. How severe do floaters have to be in order to get an FOV? Is a 20-year-old woman too young for the surgery? It would be life-changing to get FOV, but I'm not sure if my floaters are severe enough. I can't answer that question for you because I don't know how much this bothers you, and only you can answer that. But I think after you educate yourself and you are able to make, hopefully at some point you learn enough about the procedures that you can make a very informed decision about whether or not the risks outweigh the benefits. I can't tell you because I don't know how much the floaters are bothering you, but I would have to say if you've made it this far to attend a webinar, at least you're considering it. And I would just say at some point, with the more that you read and learn, at some point you'll probably come to a point where you can make an adequate decision. Sanjay says, hello, Dr. Wong. Can FOV cause any type of long-term vision problems or vision distortions? If so, what are the chances of this happening? You know, that's a really open question. I don't know. Generally, I counsel all of you about the chances of going blind from the infection, and that would be certainly at most one chance in 10,000 of getting an infection that could blind you. A retinal detachment could occur, which could lead possibly to some permanent vision loss, but maybe the chance of that is around 2 to 3%. Generally, there are no long-term sequelae to having a vitrectomy, or at least that I'm aware of. Kareem says, to my knowledge, and correct me if I'm wrong, most of the scary complications occur due to hypotony. How good sutures can prevent hypotony? And is there any additional measures to hypotony? I think hypotony doesn't, it sounds as though there are some that feel that hypotony happens all the time. The only times that I am aware that we get hypotony is perhaps the next day. I would say 20 to 30% of patients without sutures may have a very low pressure, but that usually improves within 24 hours. I'm not aware, although I've read of people having long-term issues with hypotony, but I think that with the methods that we're using, and if we use sutures, it seems to be a non-issue. So to avoid additional measures to avoid hypotony, what I normally do, especially with my out-of-towners, is I do put stitches in because that's one less thing we even need to worry about. Why bother with it at all? Lynn says, I had an acute PVD in February, almost 3 months now. I have noticed that the Weiss ring has gotten larger but more translucent. Is this a good sign? I don't think that matters one way or another. It probably is repositioned in the eye, so it seems clearer or smaller or larger. I don't think it matters at all. It feels like my pupil is constantly being pounded by the ring. I'm still getting flashes in dim light. After you have a PVD, you may get flashes for months. As long as you've been examined by your doctor and there's no tears, there's really nothing to do but wait it out. The flashes can be there for a long, long time, however. Jose says, when you do a vitrectomy, in what parts of the retina do most tears occur? As I showed you in the beginning, most of the holes or tears, and we'll look again, in the anterior part of the eye or the front part of the eye. So if you look, the gray ring shows you where the anterior retina is, and that's the area where all the holes and tears that's where all the holes or tears will occur. Ralph asks, I meant how long is the procedure itself? Procedure itself generally is about 10 to 20 minutes. When do I know? Jose says, when do I know if it's a good time for undergoing vitrectomy? I have to wait for the vitreous to get really cloudy. No, and that's very similar to the other question just a moment ago. I think at some point you and only you can tell when this is bothering you enough that you need to really consider this. John says, where can I learn more about frill? I don't know how big a deal it is or how likely it is to occur. Can you predict the risk during the exam? No, I can't predict the risk. I know it does occur in younger patients who have floaters in both eyes. It is generally not an issue with older patients who have had a PVD. It is one reason I have changed my practice to induce a PVD, because it definitely decreases the chance of getting frill. And I think this brings up a really, really good point, is that the goal of surgery is to significantly reduce the number of floaters that are bothering you. If you end up with frill, that doesn't mean that this is the end of the world, nor is this a complication. If you read online, it seems like, oh my goodness, this is a huge complication. It's actually not a complication at all. Excuse me. My goal for you is to get you better without doing any harm. And I do my best to reduce any chances of frill and to reduce as many floaters as possible. If frill results after surgery, it is possible that we can operate again. Again, my goal is to reduce the number of floaters without causing any permanent damage. And frill is not permanent. As far as learning more about frill, I think I have a couple articles on my website, Vitrectomy for Floaters. I'm sure there are all kinds of forums out there where people talk about it. Frill, in my mind, is that area of, you can see the area where we stopped removing vitreous. So it has been my practice after I create a PVD that I go as far in the far periphery or side retina of vitreous as possible. David said, I'm currently living in Maryland. That's close. And I'm probably leaving Maryland in late August. Could I have a vitrectomy in one eye in mid-June and the other eye in mid-August, about 8 weeks between vitrectomies? I think that's something we can discuss during your visit, but I think it might be possible. I'd rather wait a little bit longer, but 2 months is not out of the question. I think that's something you and I need to discuss privately. Jose says, I have thinning of the peripheral retina. It's most likely that I will develop a tear during FOV. No, the chances are probably about 2 to 3%, and that's about it. And if I do, or if I'm able to recognize a tear during the operation, just like this picture here, I can usually treat it with laser and it suddenly becomes a non-issue. Don says, hi, Dr. Wong. I'm 60 years of age. I had LASIK surgery 15 years ago, and my vision is 2015, both eyes. That's terrific. And I think, Don, you said, will a vitrectomy decrease my vision? Floaters have been driving me nuts since 23 years old. It should not decrease your vision at all, Don. John says, for how long after vitrectomy is there elevated risk of retinal tear of detachment? I am planning an international trip next winter, so would not be near good eye care for 10 days. I'd wait a good 6 weeks, give it just in case something happens. A tear can, retinal detachments can happen almost anytime, but I would say if it's related to the surgery, I think it's prudent to be really wary of this for the first 4 to 6 weeks. Bob said, what is the time of recovery process for FOV? 1 week. It depends on what you mean by recovery. Visually, it's quite possible that your vision comes back within, 1 to 5 days. Your pupil may be dilated for 5 days. You're going to be using drops for several weeks. But as far as function's concerned, I think in almost every case, I'm recommending complete full activity by day number 2. Patrick says, I'm 34 and have a PVD and need FOV in both eyes, but I do get iritis in my left eye once every few years, which is treated by medicine. I haven't had iritis in 3 years. Would you see a problem with doing FOV in this eye or recommend taking some preventative measures to stop potential flare-ups after FOV? Thank you, says Patrick. I think that it's quite possible to proceed knowing that you are prone to having iritis. It might be there are some measures that we can take prior to having the surgery that might decrease the chances of it flaring up. It's nice to know that you are well controlled with just the steroid drop. So that's a good benefit, or that's an advantage rather. Jose says, what is the probability in percents that a tear can occur in the macular area? Well, Jose, as I told you, it's very, very unlikely because all the tears happen in the anterior part of the retina, whereas the macula is in the posterior part of the retina. And maybe I can show that here. So most of the tears would be here in the front, and the macula is way, way here in the back. Bob says, are the needle sizes smaller now than they used to be? 25 gauge is smaller than the standard 20 gauge, which has been the mainstay for years and years and years. There is something thinner called 27 gauge, but I don't think that is necessarily any better than the 25 gauge. I primarily use 25 gauge. I do not like 23 gauge. I actually haven't used 20 gauge probably in about 6 or 7 years. Lynn asks, do you do core vitrectomies, and do you think that surgeons will start using 27 gauge soon with topical anesthesia? I think some doctors may do it. The problem with 27 gauge is that I'm not sure if all the kinks have been worked out. 25 gauge we understand very well. 27 gauge, you have to change the operating technique just a little bit. And may actually add time to the operation. You could do 25 gauge with topical anesthesia. I'm not so sure if there's any necessary benefit to that, except for the fact that it sounds really, really intriguing. Kaushik asks, are floaters always a symptom of PVD? No, a PVD can be completely asymptomatic. It's just that most new floaters are related to a PVD, and most new floaters need to be examined within 24, 48 hours, 72 hours to ensure that there's no tear. There is no way that you can tell as a patient if new floaters are related to a retinal tear or retinal detachment. So you always need to get examined. John says, my younger brother suffered a retinal detachment when he was about 50. I am 60. Does this family record increase my risk of a tear or detachment? I doubt it. There are one or two familial syndromes which increase the risk of retinal detachment, but I think you would be well aware of that. I think it just means that your younger brother was healthy and normal, as are most patients that get retinal detachments. And unfortunately, he did get a retinal detachment. Most patients in my career that I've had to operate on have normal, healthy eyes. Jose says, if a patient is so anxious and is so afraid about surgery, you have to use general anesthesia, or it's okay in twilight condition. I'm not about to engage in any situation where the patient might get harmed. So that if there is too much anxiety, I think we'll have a conversation about using general anesthesia. Aaron says, apologize if this is an odd question, but there are prices for the procedure on your website? No. I have not been able to find it and curious on how much I should be saving up. If you have questions or concerns, and Chrissy can chime in just a few minutes, you can email Chrissy, and her email address will be coming up with regard to questions about coming in and insurance, so on and so forth. Ralph says, how much pain is there after surgery? Usually not much. I don't think I ever write any prescription pain medicines. Tylenol or Advil seems to be just perfect. Jose says, how is vision when the patch is off after the vitrectomy? I know it's blurry, but I want to know if it's only blurriness or it's combined with multiple vision or halos or fog. It's generally just blurriness from what I understand, and that improves over the next several days. Michelle says, for a 51-year-old male with essentially a snow globe situation, 100 plus in each eye, in both eyes, that suddenly started 3 years ago, does the fact that I have a partial PVD in each eye make it easier to induce the PVD and get an excellent result? I'm not sure that I'm aware of a partial PVD. I'm guessing that you have a PVD, but in any case, I think it would be very simple to help you. Ralph, what is the difference between a regular vitrectomy and FOV type procedure? Vitrectomy is the clinical term for what I do. FOV is the layman's term for what I do. Vitrectomy is the core operation or core procedure that a retina specialist uses for a variety of procedures. For what we're talking about tonight, we are talking about using a vitrectomy to remove floaters, hence the name floater-only vitrectomy. I can use vitrectomy to repair a retinal detachment, to remove an epiretinal membrane, to repair a macular hole, etc. And that's how the term FOV came. But technically, vitrectomy and FOV are absolutely the same procedure. Lynn says, do Weiss rings continuously change position in the eye, and do they ever sink? They can continuously change position because they're just floating around in your eye. And do they ever sink? Yes, they can. They can move to the side and become less noticeable. Troy says, are you aware of any non-surgical floater treatments in current research that could be practical in the future? Is there anything you know of in terms of enzymes, eye drops, or holy grails of floater treatments? I'm not aware of anything that is actually being studied. There are lots of websites that promote drops, but I'm not aware of anything undergoing clinical research that may have any meaningful use in this arena. Sanjay says, I've had several episodes of central serous retinopathy in my right eye. What would that prevent me from getting an FOV? And would that increase my risk of complications such as retinal separation? I don't think it would have any bearing whatsoever. Lynn says, what do I think of laser surgery for a Weiss ring? Well, there's not too many doctors that actually do laser vitreolysis. The doctors that I'm aware of that do it are not retina specialists. Retina specialists don't think it's the wisest thing to do. I do know it's very popular, and certainly you would need to talk to one of the doctors that does this to determine whether or not they think it would be suitable for you. Michelle says the crystal worms that are seen by the patient, are those definitely not debris from a PVD? The crystal worms that are seen by the patient, are those definitely not debris from a PVD? I'm kind of at a loss as to what you mean. I think that floaters can come in any shape or form, translucent or not. And as long as they move to and fro, I generically call them floaters. I don't know if the particular shape or size has any significance. Don, I don't think vitrectomy will change anything from your laser vision correction that you had a decade ago. There's no reason why it should. The vitrectomy should not change any of the parameters, including the curvature of the cornea, which is what the laser vision correction did. Kaushik says, I have just a small negligible floater in my right eye. What happened? Floater in my right eye. Would getting LASIK increase my number of floaters? I am nearsighted. And again, this is very similar to Don's question. Having a corneal procedure, laser vision correction, should not have any bearing on your ability to have a vitrectomy. And vice versa. Having a vitrectomy should not have any effect on your ability to have LASIK or your results after having had LASIK. Jose says, when floaters are so numerous in all types and sizes, and again, it doesn't matter about all types and sizes. It's just that whatever's moving back and forth in your vision, those are just called floaters. I think that it's better to have a vitrectomy rather than a laser treatment because many shots can damage cornea or lens. Am I right? I think you're right, but most of the concern with the laser is that it can impart energy into the vitreous, which can lead to retinal tears. That's my biggest concern with laser vitreolysis, but it can be useful in certain situations. Ralph says, what's the type of anesthesia that I use in a typical procedure? I use light sedation, or what we call twilight. You have an IV. You generally get a sedative that puts you out for about 5 minutes, at which point we numb your eye up. And it is possible and usually likely that you are completely awake yet comfortable for the procedure. Bob says, what day or days do you do the operations? Weekly? For most of my elective procedures, and this would be an elective procedure, I reserve Fridays to do most of my operating. That gives, I will see you Saturday. That gives you the weekend to heal without taking a lot of time off. And in many instances, you're able to go to work on Monday. John says, when estimating the probability of vision loss, is it correct to multiply the probability of a tear detachment 2 to 3% by the probability of vision loss from a detachment? I don't know this, so that the probability of vision loss is much lower than the 2 to 3% statistic. I don't know how to answer that. I haven't really considered that. I think the problem with what you're asking is that there's only one or two possibilities of having vision loss. I think the most likely, the two biggest situations which could lead to vision loss are blindness from infection or retinal detachment. I think other things can happen. I don't think that either one of them are related, so that I don't know if multiplying the two of them together makes sense. And I'm not a statistician. I'm not that great with numbers, but it's probably something you could better answer than I could. Eugene says, does a soft cornea make FOV riskier? I don't know what a soft cornea is. Never heard of such a thing. So the answer is I don't think so. Is the eye black and blue after the FOV procedure? It can be. It usually is not. Sometimes when we deliver the retrobulbar anesthesia, which is a retrobulbar block, that's a numbing injection behind the eye. Sometimes we can get hit a blood vessel in the skin, and you can get black and blue, but it generally does not happen. Don says, will my eye be as strong as it was before vitrectomy? Yes, I would assume that it should be. I do play basketball and a runner and do spar and boxing. Can I still get hit in the eye without worrying as before? I would say yes. Once you have the operation, I think you can resume full activity generally in a very short period of time. Kaushik says, have you ever come across cases where floaters go away by themselves? Yes, and I think this is why we don't offer the operation right after you notice floaters, because I think you want to be as conservative as possible. Because the vitreous is dynamic, meaning it moves and it shifts, it's quite possible the floaters resolve. After a PVD, after I see patients who have noted floaters secondary to a PVD and they're bothered by those floaters, I generally tell them that we're not even going to consider talking about removal for several months. John says, different way to say my last question. Even if I experience an RD, are you usually able to repair it and avoid vision loss? I'm usually able to repair it. It depends on the timing as to whether or not we avoid vision loss. Don, meaning that if we get to it soon when it's small, chances are you're going to be fine. Don says, how long is the procedure from start to finish on an otherwise healthy eye? Again, that's about 10 to 20 minutes of actual operating time. If you had a PVD, it's shorter. If I need to induce a PVD and put in stitches, it takes a little bit longer. I'm going to answer just a few more questions, and then we're going to stop and hear from Chrissy. Troy says, is it likely that a retinal tear related to the surgery would turn into a retinal detachment? It's possible. In most cases, I can diagnose the retinal tear at the time of surgery. What is the prognosis after a retinal tear? Prognosis is quite good. We're on the lookout for a retinal tear after the operation, so we're generally able to identify it early, or at least we're able to identify early retinal detachments. It's one of the things we worry about. Vision loss does not necessarily have to occur. What is the prognosis after retinal detachment? Asked Troy. Well, it really depends on when we get to it and how big it is. So every case varies. In most cases, we are able to get to it in a timely fashion. Aaron says, so it is safe to say after FOV, the floaters will never return. No, it's not safe. It is safe to say that, but it's possible they return. They generally do not. It's another reason to induce a PVD so that there's almost no vitreous left that could separate from the retina, and it obscures your vision. Can some floaters remain after an FOV? Yes, it's quite possible. You have to remember that I can see everything at the time of the operation. I can see all of your vitreous. I really can't see every floater that you see. I try to remove every piece of vitreous that is visible to me. And in most cases, we're quite successful. And again, I'm going to highlight that our goal is to reduce the number of floaters that are bothering you. If you have one or two after the operation, we've still significantly helped you. And I want to help you, again, without creating damage. Ralph says, do most retinal specialists do FOV for floaters? No, most do not. That's why we're here. Lynn, how many FOVs do you do a week? I just know that I do it weekly. I do quite a few operations a week. Jose says, my local doctor in Peru told me that I had better not undergo a vitrectomy. That he is not going to perform a vitrectomy on me. But my doctor in Ecuador told me that it's a safe procedure, but has risks. But it is effective in floaters and easy to perform. Is my doctor in Ecuador right? I think I'm saying the same thing as your doctor in Ecuador. Kaushik, I had one floater in the right eye initially for mid-March. I have, for the past week, been seeing another one which is vaguely visible and keeps floating once in a while. I had my first doc appointment on the 20th of March. My retina was fine. He's asked me to come back on the 1st of May. Should I visit him right away? I think if you have a significant amount of new floaters, you should see him right away. Bob says, thank you for your valuable time, Dr. Wong. Thank you for thanking me. Tyler says the same thing. Yes, thanks again, Dr. Wong. You're very welcome. Aaron says, well, thank you. Aaron says, thank you much for your time. Highly appreciated. And Don says the same thing. You know, I'm very happy to do this. I think this is just a great way of communicating. There's not much credible information, health information out there on the internet. I think I can do my part to reach out and, start a relationship with you guys. So I'm happy to do it. I think at this point, I'm going to turn things over to Chrissy, who wants to say a few words about what she does, what part she plays in this process.
Hey, everyone. Thanks for joining us tonight. A lot of you might already know me. My name's Chrissy, as Randy said, and I'm his online surgical coordinator. So I assist with basic things, basic questions, scheduling, insurance inquiries, costs is a big thing I go over. So I just wanted to go over a couple things. As I stated, I'm Randy's online liaison. So that means I work strictly in cyberspace. It's hard to get me on the phone. My Google Voice number is on the website along with my email. But I just wanted to note, you can call me, but during normal business hours, I actually work for a different office. So email is usually the best way to get a hold of me, and I usually will get back to you within a day or two.
Hey, Chrissy?
Yeah.
I think turn down the volume on your speakers.
Okay. Hang on one second. All right. Is that better?
Sounds much better.
Okay. All right. So, insurance questions are another big thing that I handle. So, and I just want to note, a lot of times medical insurance does cover FOV. I just want to make sure that everyone knows that. I can't promise it always is the case. But if you email me and let me know what kind of insurance you have, I can help guide you. I've been doing insurance a long time. So, I can definitely give you some information if you're curious to see if, you don't have to be a self-pay. If you have insurance, it could be covered. So just email me. Another thing I wanted to mention is, if at all possible, if you do come and see us, try to bring a driver if at all possible. The reason we say that is that anytime anesthesia is involved, the surgery center, you cannot drive yourself, obviously. And they really, Randy, are they still not okay with cabs and Ubers and things like that?
I can't globally say because it's really not up to me. It depends on the doctor who's in charge.
Okay, gotcha.
It's best we can work around it, but if there's any way possible you can have someone come with you, that's the best case scenario.
Right. Okay, and also just to note, this is another common question we get, flying after surgery. Typically there is no problem with that. Randy, I know that gas is the question there, but whenever it's a floaters only vitrectomy, typically, flying, that is no issue afterwards. And, lastly, I do all the online kind of stuff, answering questions, but there's also an in-office surgical coordinator. So, reach out to me. And then if you are ready to schedule, her name's Ashley. So while it's kind of hard to get me on the phone, she's in the office when Randy's there. So again, just email me and I will do whatever I can to help answer your questions, etc. So my email is actually right there on the slide. It's rwongcm13@gmail.com. And again, I'll usually get back to you within a day or two.
That's awesome. All right, everybody. Christy, thanks again so much for your help. Until next month, we'll see you. Thanks for joining, everybody. Take care. Hope to see you soon.
Good night. Thanks, everyone.